But sir, you've heard the rumors which are going around
Which rumors?
that you doctors, when you are diagnosing, you are using ChatGPT.
No.
Good morning. It is in the public domain that antimicrobial resistance has become a global threat. So this can be due to prescribing habits and dispensing practices. Ladies and gentlemen, my name is Shevede Moses, and I'm here with the University Talk Show. So with me, I'm with the medical students and also the pharmacy students. And we have a motion that reads as I quote, "This House believes that health workers are responsible for antimicrobial resistance." So, of course, either none of the sides will be arguing whether they are opposing or proposing to that motion, but they will give us an insight and more details on what that motion entails. So, before we can start, I'll give time to the people on the panel to introduce themselves, starting from my left side. Sayubat.
New bird. Yeah, a pharmacy student.
I'm Elias. Mwenye Elias to be specific, a fourth year pharmacy student.
My name is Surens Kadwa, fourth year medical student. My name is Molinga John, fourth year medical student.
Interesting. So I have a few questions for both sides. But before we can start, I want the viewers, to have a better description of what antimicrobial resistance is. So starting from the pharmacy students, can you define what antimicrobial resistance is? And perhaps you can use layman terms so that it can be a better conception for everyone, for the general populace.
In a layman's language, microbial resistance is simply the inability for drugs, usually antibiotics, to effectively kill or get rid of or eradicate the microorganisms that is causing an infection. It may be a virus, a fungi, or also a bacteria.
Do you also want to add something? Or perhaps something?
Yeah, so antimicrobial resistance, it is simply the ability of microorganisms such as bacteria, fungi, parasites, and viruses like to survive and multiply in the presence of antibiotics, which can be caused by alteration in the gene structure or the transfer of a resistant gene to another microorganism.
Interesting. So, as a summary of what antimicrobial resistance is, perhaps I can use Bemba to define that. So, nifidefya kwa wati akashish akadeta marwere apusana pusana nga wakapera omuti kali kanokufa hivyo fini. Okay, so I think that's the best way that we can define it in layman's terms. Okay, so to start with, what do you think is the role that healthcare practitioners have been contributing when it comes to antimicrobial resistance? Do they have any role that they play when it comes to antimicrobial resistance? Have they contributed a certain portion of it to the extent that we are in at this point? Perhaps I can say
For sure. We can talk of health-related issues without the involvement of the same health practitioners. So for there to be an healthy issue of antimicrobial resistance, we, the custodians of the same team, we are the very people who are in front of causing it. Talk of antimicrobial resistance, as my brothers have articulated very well. So this is whereby it actually comes about when a bacteria which was sensitive to an antibiotic before then gains resistance, whereby it's now unable to respond to the antimicrobial that you are giving. So that's how it comes about. So you find because of the same use of antimicrobials, especially some people misuse metronidazole, fragile and stuff like that. You find to say the organisms that they have the microbes that are there, they start gaining resistance to that drug. And of course, it's us who are giving them the drugs. It's either the pharmacists who dished out, or the doctors who are prescribing, and yeah, the nurses who are administering. So it's a healthy thing, and all health practitioners are at fault.
Yeah, so just to shed more light, as health professions, of course, we have a role to play because you find that a patient comes, they have been put on an antibiotic, then it's supposed to last for 5 days, the treatment, but after 3 days, they come to say they are not responding to the medication. The course has not yet been due, but yet we prefer to change the medication, thus resulting in what? In microbial resistance, because the course is supposed to last for 5 days. Instead of encouraging the patient to adhere to the treatment until the medication is able to be put into effect, but instead we rush into what? Changing medications. And we are also into, as health practitioners, we don't very much console the patients on these factors which lead to microbial resistance. We just dish them when we have the medication, they come as a pharmacist, instead of telling them the importance of adhering to the strict what? Regimen that has been prescribed. But we just tell them to go and take the medicine, and we do not have an impact on how they are supposed to take it. So emphasis should be made on that as medical students, also as medical practitioners. We should enforce that because we are the custodians of that health. A patient is just a layman. They don't know what microbial resistance and its effect on their lives is. So we have a lot to play, a big one for that matter.
Interesting. So coming to the doctors, coming to our doctor students, our medical students. So your question is, you guys are responsible for prescribing. So how do you think these prescribing habits have contributed to antimicrobial resistance?
I think I'll go first. So, when you look at when you are prescribing, most of the doctors, you find that they are using terms like just in case without confirming with the lab. So you find that they end up prescribing something that's not going to eliminate the fully the bacteria. So you find that the more you are taking in the drug that's been prescribed for the wrong thing, you find that the time you'll be taking that, the body has already gained the tolerance. Also, there are situations where we have broad spectrum and narrow spectrum. Then in a situation where you know that you can use a narrow spectrum drug, use a broad spectrum drug, you find that yeah, it's the same thing where you know that you can kill these people with let's say US can kill Zambian people using guns, but they end up using an atomic bomb, which is kind of wasting things. So you find that those the body will start gaining resistance, and then all those things. Also the long duration. So you find that when you're prescribing, you put the wrong duration for the drug. You find that that will also lead to the bacteria being resistant to the drug. Yeah, so all those things, and there are many more. And you find that for certain things like cold flus, and then you start prescribing drugs which drugs which are not necessary. You are not even know that the doctor is not supposed to prescribe the drug. So all those things lead to high resistance. Yeah, so also contribute. So when it comes to prescribing drugs and all that. So one thing that we should know as medical practitioners, we should know that we are dealing with smart microorganisms. And we know that these antibiotics that we are given, or this medication that we are given, it's more like it is a poison that is meant like to kill that bacteria or to inhibit the growth of that bacteria so that the immune system can have the ability to eradicate the bacteria. But the problem now comes in cases whereby we have to put in mind that an antibiotic, it can be ineffective, necessary, or unnecessary. So let's say in terms whereby a patient comes by the hospital and you prescribe medication which are ineffective. Like there's no point of giving those medications. So it will end up prolonging the disease, and you have that patient like in the hospital setup for that long, and that would bring up another disadvantage. So like those patients, they can be exposed to another microorganism, and all that, and they can make the situation critical. Then the other thing we should know is that, again, these antibiotics, they can be unnecessary. So when these antibiotics are unnecessary, so it simply means like you are giving those antibiotics. There's no point of even giving them. So let's say an example that my colleague gave: a person comes in with flu. We know that it's a viral infection that has caused that, and you end up prescribing antibiotics and all that, which is not good. It is wrong. So these creatures that we're dealing with, they are smart in the way that if you give a certain medication and it's not the one that it is meant to be given, they will come up with certain strategies that it will make them like how can I say, like they'll take advantage of that antibiotic at the end of the day. When someone comes about with a certain infection, bacterial infection, and they'll end up being resistant. So these things that we're dealing with, they are smart. So when it comes to prescribing, we should be smart as well. Like we're supposed to be coming up with a definitive treatment. A patient comes, we should make sure, like at least we should have fast laboratory set up, whereby a patient comes, we take our samples fast, and have the lab results as soon as possible, so that we can come up with a definitive treatment, and we should treat that disease.
Interesting. So you talked about sometimes prescribing without having proper lab results, and there can be some other challenges that also contribute to antimicrobial resistance, such as lack of diagnostic tools and also heavy work overload, especially for the doctors, on the doctor's part. So do you think that has also contributed to antimicrobial resistance, and to what extent?
Yes, it also contributes to drug resistance. So we should at least upgrade in that setup to an extent whereby at least we should have fast diagnostic tools, which will be like making the work easier for us, so that when it comes to prescribing medication, at least we know what we are prescribing for. Because let's say in case a person comes with an infection, which we don't know of, but we just know that it's a bacterial infection, because of how it's presenting and all that. There is narrow spectrum drugs and broad spectrum drugs. We'll give a broad spectrum antibiotics because we suspect that that's a bacterial infection, so that it can help us with that. But at the same time, again, we are creating resistance without knowing or being aware of that.
Interesting.
So I think we should enhance in that.
But again, as the saying goes, bomba na matulu kwete. So if at all we are in a resource limited country as settings, so how do you think you as medical professionals are able to enhance your skills to really counteract this antimicrobial resistance? Because of course you can say you talked about the empirical treatment that goes on, and before even the culture sensitivity comes about, you can prescribe something for the patient. Yes, because we know this from our studies. We know how some certain antimicrobials, when they infect a person, how they present. We understand. So we do kind of have this guess in our mind. That's the empirical treatment that he's talking about. If I see somebody presenting with the symptoms of gonorrhea, for sure, before I even get the sensitivity culture and stuff, whatever, and the patient is in agony and they need to be attended to, you can prescribe something fast. That's what happens. But it's also leading to the same antimicrobial resistance. At the same time, it's also AOP, because if at all you delay, the patient dies. Again, if you do that, you are thinking of antimicrobial resistance and all these other stuff. So I don't know how we can just enhance our skills, like in our setting.
So, Bagelo Navagaigan, my name is Adike. So a guy gulisa tomato iri 8 at temperature, free delivery by Queensville. And then if you are not within Queensville, you can buy for at least temperature, and I'm going to deliver for free. Nkubwera chela guy. Cheers.
If you're looking for where to buy some nice, good tomatoes, you can hit us up. Our contacts are simply in our description. Thank you.
Yeah, so like looking at our setting, like in our setting, I feel like the way forward is having like taking a proper issue, since we, like, before giving a prescription as doctors, we take a thorough issue, and then in the issue certain let's say gonorrhea presents in a certain way, so would thoroughly ask a patient, and then we prompt them to find out how the symptoms were coming about, the onset and everything, so that we make a proper diagnosis, because most of the diagnosis comes from 70 to 80% of the diagnosis comes from history taking. And then the labs are important to confirm, and then they're also important, for legal issues.
But sir, you've heard the rumors which are going around.
Which rumors?
That you doctors, when you are diagnosing, you are using ChatGPT.
Not just ChatGPT.
Yeah,
You find that a second year medical student will be calling home to say when they are sick. No, we are doctors here. We can just take some azithromycin, and those medications are reserved for last line of defense. So also as medical students, you should encourage your juniors to refrain from prescribing unknown things. Those are leading to microbial resistance. Yes, they just Google the symptoms.
Another
without
thing,
the actual patient.
If they are googling symptoms like that, they are not different from the people at home.
Because another thing, this issue where a lady walked in, she was prescribed some antimicrobial for the flu, actually.
Yeah.
So first of all, flu, you don't prescribe antimicrobials, but she was given antimicrobials. But the actual cause of the flu that she was experiencing, because she was on a monthly period, you get that? And you understand to say the prostaglandins which are released. There's prostaglandin FA, which is able to cause flu-like symptoms in the respiratory system. You get that? So now, if this patient comes and you're just like, oh, it's flu, bah! And you get that? By not knowing clearly what is happening, what's the story. And I like what he was saying to say, we take thorough history, but maybe it's just you, but some people,
I feel like there's also a point.
I've also gone to the hospital before. I'm talking to I don't know if they are clinic officers. This is your cousins, my clinic officers.
It's your cousins.
I don't know if they are the clinic officers or it's a doctor. But I was talking to this guy. I'm sick. The guy is on his phone. So that's where the concept people have to say, you guys are using ChatGPT now for diagnosing us.
Maybe my brother was just on WhatsApp or something. Within the experience. Checking out the experience. But I also feel like in a situation where they prescribe the for flu, the example you give,
antimicrobials.
I feel like we should establish a proper communication like between you guys, us and you guys, because there are times when I can be unsure, I can be sure, but there are some times when you're unsure when prescribing something, say drugs, I can make a call. I can make consultations. I consult from you guys.
That's a good idea, but in practice it doesn't really work like that.
No, but we can make it work. You've seen, we can make it work.
Yeah, sure.
So that's the reason why we are here, as students in the study, and we can bring about a change. So if we have that mentality, then we won't go anywhere, and we are not going to work on this antimicrobial resistance, and we are not going to do anything. Like there's no war without soldiers, so we are the soldiers.
Definitely.
We are supposed to lead first.
If doctors from you've seen doctors, the way doctors from Obs and Gyne and the nurses work, those guys work together. If they can do it, we can also do it. In terms of, because drugs can kill someone.
Definitely.
Can kill someone.
If you check start, you find to say, is it? I don't know if it's 70% of the deaths, due to medication errors.
Yeah.
I can give you an example. A patient comes, they had just heart failure. Okay. Not even heart failure. What can I? Yeah, which example can I give? Anyhow, if I remember, I'll give an example.
Okay, just make a point.
Okay.
Yes, you find to say the same medications that you are prescribing are the same medication which is causing another condition. You
Yes,
get
it's in.
a patient comes, you give another pre and what's this? Spinal another pre, then you give spironolactone medicine. You get another pre has got this effect of causing potassium retention.
Or cascade prescribing.
Yes, you get and of course spironolactone it also causes potassium retention. You have hypercaren. The person came for hypertension. You are now attacking the heart. 3 months down the line, the patient has got heart failure. You are treating for hypertension. So because of the same, I don't know. I think we are not studying very much.
Then again, the other case, antimicrobial resistance, it just doesn't come only about with prescribing drugs and all sorts of things and all that. So at times now, you've seen antimicrobials or antibiotics, they are meant to treat, you've seen, and kill these bacteria, you've seen. But now, when you look at the agricultural setup, like things have changed. You've seen, like things have honestly changed. Then they're using those antibiotics to speed up the growth of animals and all that. You've seen that. So you find that 60% of antibiotics are being used in what you say in livestock farming and all that, so that they can speed up the growth of the what you say of the animals and all that. Then we know animals, they have to defecate and all that, so they'll end up again bringing about resistance in the microorganisms that we have in the what is in the soil and the microorganisms that they have themselves in the body. You've seen. Then you find that nowadays these meat products that we buy when you go in ShopRite and all that, you find that a lot of them, like, they've been treated with what is antibiotics. So we can work hand in hand. At times a patient can come with antimicrobial resistance, like hospital. Now you check, you might end up putting the blame.
I think the way they do that is is it Malive and microbial that they do give to the same thing, or they are dead?
When they are, I think, also to just shed more light on how they do it. I've seen in most cases these people who grow chickens, they use septrin to treat cough. But since they want to make a profit, before even the treatment is due, they'll start selling. That means the treatment wasn't well
in a chicken.
Yes. They'll give septrin. Very common. Very common. I've seen it a lot of times. Yeah. And we the medical students, maybe as a bwera na ka 10 kwacha ufuna ya bando cha bea nifuna ko septrin nkuku zikoso moja. Nikakana inazaenda. No, Mr. Karuba. Me, my chickens, they are sick, but the pharmacist, your colleague, has refused it. You owe me in Congole. So, write some he gives me. He writes. You see? So, septrin will be used now since they want fast money. Zama school fees. Then, septrin will be used in complete treatment. Then, those are the same microbes when we consume. The strain that has already acquired resistance will be in us. So meaning when you come to treat, it won't be effective in humans, but the source is from where? Agriculture sector. So we should also advocate for stewardship in terms of we tell them the dangers of this, especially these keeping livestock.
So we should work hand in hand, the doctors and the patients, or the people at large, you've seen. So we should work hand in hand for us to deal with this pandemic or the devil to mankind. Because trust me, in the next 50 years, you would find that most of the cases or most of the death that we are seeing, it's because of antimicrobial resistance. So the only way we can work in unison or in unity, it's us, or when we are buying these meat products and all that, let's try to check, because they write on that thing. You would see that okay, this meat was treated with what? Antibiotics. And when you see that, please don't attempt buying that, because it will put you at the risk of
Sir, if you bought meat from Maramba, sir, they don't write that. And that's the cheapest for students like me. I'll go and buy meat from Maramba. You won't see the label that it was treated with what. And these local slaughters, they don't even abide by the slaughter rules. There is no vet to confirm whether this cow is safe to eat or not. They just
so the
slaughter
point here
as
is
a
not about
community
looking at Maramba or
and
what,
eat.
but we can start with these minor steps in there.
But
Most of the students, trust me, we go ShopRite, Spar, and all that to go get our meat products and all that.
Yeah, what I'm saying is it's not about the Maramba thing. What I'm trying to communicate is we should sensitize them that before
what do you
killing
mean
there
both
is
by
this.
Maramba thing?
The Maramba procurement.
But guys, putting the public health aside, I think we also talk about the public health. I think the problem is just between you guys and us. So now, having said that, because the communication is poor, because let's say I prescribe something, and then you think something would work out, and then there's no way you can just change the prescription. That I think we need to communicate. I mean, check out. I'm still going. Yeah, I feel like we need to communicate. Now, where is the problem? Is it people being egotistic, or it's just people not understanding what other people specialized in?
So for that one,
like what the
which
guy
one
is
is the
trying to
problem?
say.
yes. So for that one, I would say people are just different. I've had the privilege of just working outside the Vincent Teaching Hospital, and even here, yes, there are some who are okay and some who let me not say that. Things are like that. So yeah, you find this. There are doctors who are very open. You get that?
Yeah.
By open, I mean they are not full of themselves. In that they are able to consult from even a pharmacist when it comes to medications. You get that? And the vice versa. A pharmacist can have just a direct communication with the doctor. Oh, Dr. Chakuti, you've prescribed this. Boy, the reason why is so.
Why have you changed my drug?
But yes, there are some doctors. There are some doctors whereby you don't even have that relationship with them. You don't even have their number. You get ka?
Yeah.
You get ka? Then they are the same ones who have prescribed. What do you want me to do? I'm also a person. You get ka?
Yeah.
And maybe from the past regime. I'm not going to worry about Rome. So that's what happens, you know. Like you had put it correctly. Somehow it's egocentric thing whereby just personal egos people have, but the system itself is perfect.
But
we have to work in harmony.
Do you think it's okay to act like that? Because
No, it's not.
Us being at school, like some like
It's
med
not.
school, we are treated in a way that our ego, like they are killed every day, whereby they're always telling you know nothing, you know
Yes.
nothing. So
No.
by the time you reach that,
You know,
You want
the
to look
thing
like
is,
you know something.
you
now.
guys, the way we are is even the way we are treated while in school is a reflection of how we act when we are outside.
yeah.
Because in as much as you are saying, you guys are your ego are killed for what, but not
Yeah.
when you come out. You get they would, yes, that era might be to manage boyfriend no power. No we sharp. But that's more for that chat. You get yeah. So that's the thing. Because you are being crushed every day, quad. You are being your ego is being crushed. You want when you come out again, you pump on the nurses first of all, you pump on the pharmacist. You get so
You know
it's
me.
because even hello, it's different from us. As we are never crushed, our egos are never crushed. That's why you find to say if there are people who have this, I would say this courage or confidence in the health sector, our pharmacists, we have this confidence of I can walk up to any office
Audacity.
with the audacity.
Plus
No,
tenacity.
chill.
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 Yes.
So bagelo na bagai guy. My name is Adike. So a guy gulisa tomato. It 8 at temperature. Free delivery by Quincy. And then if you are not within Quincy, you can buy for at least temperature and I'm going to deliver for free. Nkubwera cheva guy. Cheers.
If you're looking for where to buy some nice, good tomatoes, you can hit us up. Our contacts are simply in our description. Thank you.
You see, that's the main reason why you guys are. You see, you're the main problem. Check out. You're making a point.
Yeah.
As from our foundation, we are taught by our consultants. Like we're always been corrected. We're always been taught that no, you don't know. Since medicine, we all know that it's a constant thing of.
It evolves.
Yeah, it
all the
evolves.
time.
You can never reach there. You can always go. But you guys, since your foundation, you always know. So meaning, if we go like in your class, maybe everyone knows. You see, that's a root foundation of being egotistic. You see,
No.
You see,
maybe you missed.
because
my
I was
point.
talking about it as being communicating
Maybe you
properly.
missed my point. You know
Yes.
what I was saying is, you know, in psychology,
Yes.
there is a thing whereby if somebody was being abused maybe by somebody in authority,
Yeah.
then when they come in authority, they also have this hedge of abusing people. You get? So what I was saying by saying as we are just with that confidence throughout is because as we are never oppressed like you guys are. You get? The reason why you guys feel this now when you come to set up to infuriate these others is because of the trauma that you got because you were being bashed of
Why adapted?
now to counteract that
No.
effect.
No.
You get?
You know,
So gentlemen, wait a second.
For that second,
I'm taking over this.
Wait. So before,
I'm taking over.
okay, wait, gentlemen. Okay, wait.
Me for this.
So wait.
Let me take over.
So
Just a minute.
order. Oh, wait.
Okay, that second.
Okay, wait. So before we can digress any further, I think let's stay within the confines of the topic.
Just 1 minute. Yeah, I'll stay in
Within the okay, if you have any points, yes.
So my point is that, so because of this misunderstanding that is there between the pharmacist and the medical students and all that, okay, pharmacists and doctors, it makes us now, like think slow than the way these microorganisms think. It's because one, it sounds funny, when you look at bacteria, they work in unison, they work in unity. But why is it so difficult for us to work together? The reason which I don't know. But it's possible we can work together, right?
And it's happening.
So listen, when one microorganism has developed like a way of resisting from that what is drug, it will transfer that genetic information. Yeah. Boy,
My brother, the transfer of those genetics is through.
Okay.
If you feel
Okay, so it's been rumored that medical students do not receive adequate training or mentorship when it comes to antimicrobial stewardship. Is there something that you can comment on that?
I don't know how it's done for them. I think they can best answer it. But from us, we are very aware of antimicrobial resistance, and this is something that we are taught. I think from second year, they'll tell you about antimicrobial resistance and all this other stuff. Our friends, I'm sure, is diagnosis.
No, that's where you get it wrong.
Wait.
That's where you get it wrong.
So perhaps you can allow him to finish it.
Yeah. So yeah. We are, but I can't answer for them. If you ask me to say if they undergo antimicrobial thingy and stuff. For us, we have if you are a pharmacist, you graduate a pharmacist now. We have antimicrobial stewardship and stuff. All those programs. I don't know for our friends, but These are our academics.
Yeah, so just to add on, I think when it comes, the problem comes in, it's not that they are not well maintained. It's just that some of them do not wish to learn from them, the custodians of the medication they give. Instead of, no, there are drugs that are supposed to be prescribed just for emergencies, but they tend to prescribe them more often than usual. You get my point? So they don't follow the protocol that has been laid upon to say you cannot prescribe this medication unless the patient is resistant. Just because of ubukaya nali mwishi bapole bwangu.
Yes, but
You-
how about in
you skip
relation
the
to
protocol.
antimicrobial
But
stewardship?
before you
So,
use
Like that
example-
training.
that's where I'm heading to. So in that sense, they don't have, I feel, because from my observation, they don't have sufficient information about such, because if they knew,
Who are they?
the prescribers, yes,
I think now it's our
I
team.
doubt
feel like
if
now
they
it's our
have,
team.
because I don't see it.
Okay.
I feel like now
Yes,
it's our team.
Yes.
I don't know if he met a doctor or something like that. Because the way he's putting it, they don't know this. They are not adequate. They prescribe this. He's putting it in a way that that's what we do.
I don't know whether
That's
it's,
what we do.
it's your nephews,
I
the
think-
clinical officers, or
Ah,
you guys,
okay,
like
no,
the
no.
prescriptions just come.
Or what?
Okay,
That's what you.
let's. I think let's
But
into that.
in our situation, we are given adequate training. We are given adequate. The only difference between between us and you guys is that us, we tend to diverse in many things. You find that a doctor is supposed to deliver a baby. Find the doctor is supposed to diagnose. You find the doctor is supposed to suture this. Find the doctor is supposed to conduct this. What? So you find that.
Surgery.
Yeah, you find that pharmacology, we know it because we did it.
We have ideas about it.
No,
We
no,
have
no, we
ideas.
learned it.
We've
We learned
learned
the same
ma-
pharmacology.
Even
We wrote the same
Drug
exam.
resistance, we wrote the same. The only difference is that after fourth year, after third year, you guys, you go now in a clinical setup. It's different from ours, but from the background, you find that we all did the same pharmacology. Just that
Yes.
you said that you studied it in second. As we're doing the anatomy, we're doing the physiology, we're doing that, and then our physiology is more like you just have to know. You just have to know how this thing is moving in the body. You just have to know how this disease is going to spread in the body. You've seen, you just have to know. It's not, you can't compromise. You get, and then others you can't compromise. So like we don't know the pharmacology, we do know the drug resistance. We wrote the same exam in our third year.
I believe
And
you have ideas about the pharmacology, but the pharmacotherapy of the actual drugs, you do not dive into depth.
we know enough to give a prescription, and
Yes.
that's enough for us.
Uh-huh.
That's
We are
enough.
good
We
to
don't
go.
because we after we prescribe, we need to. We don't have to look at
I think
how is this drug made properly. How is this?
So-
We just
so-
know
so-
how the
I think you know.
So
another thing-
in short, you are saying, if I heard you correctly, you are saying the people that are in charge of prescribing do not have adequate information on the
Some,
drugs.
not all.
you
Oh,
didn't
you
use that.
said- you didn't use some. You
Some.
said all.
Okay.
So when you say some, then it goes to person doing this.
Because when I say
Yeah,
when I say
individual,
some,
individual.
because these guys you are only found at hospitals. We have nurses in the clinics. That's where also some of the origin of microbial. Go to the clinic where I come from, you find that a guard is prescribing, and a cleaner is the one dispensing. Such are factors that are found in typical rural areas. That's why I said
now that is the issue
some
of the government.
prescribers. As a
Yeah.
pharmacist, me, I
The issue
just
of the
dispense.
government.
You know, third
That
day
for
we
the
are
most
given,
part is not our blame.
yes, that's why I'm saying some prescribers. When I say
Yeah, but-
prescribers, I'm not. That's why I'm not saying
Yeah,
you
but-
directly.
But,
Yeah,
I,
that's-
but I,
students.
that's a
I,
major
again, I heard
They should
you
know, we can
mentioning
work
to
without
say
them.
because a doctor has a lot now diverse things to do. It's like pharmacists are only. You know, actually, a pharmacist is not just a dispenser of medication.
But in Zambia, just
being
a
there.
dispenser.
No.
I know.
You know,
No,
yeah,
that's
it's
the
not-
odd
no,
thing, my
okay,
guy.
Okay,
It's-
wait. I think we're now digressing.
The thing is,
We're now digressing. Maybe
our
we
law
can-
in the hospital. Our law is in the hospital. You get that? That's there are some limitations to it. But if you go for industry, a pharmacist, we work in industry, we work in regulatory authorities, we work in making the same guidelines that you guys are using when prescribing the medication. We are the frontliners when it comes to that. You understand? Eh? Yeah. So it's not like limited. It's just that in the hospital when we come, just like you when you come to industry as a doctor and you find me manufacturing of medication, you won't have any say. It's me there. I'm the boss. So we understand even you. The hospital is yours. You get the hospital is yours. But just like when you go to industry, when it comes to the physiology of the disease, we would want to ask you some questions to say, boy, don't mange EIF, because we are trying to make this medication in such a way, so. And you can bring in your expertise. No, HIV was so. And we would work together.
So yes.
Even in the hospital setting, you guys, when you are working, sure. When it comes to medication, you can call on us for none can, to perform our or to lend our expertise in that area. So it all goes now to
That point we made for communication, where
communication.
where you find that
It's a great factor.
you feel like you think a certain drug could work better than the one I've prescribed.
Yeah.
You call me, why do you think this drug? You also explain, I think this drug, and then I feel like there's no problem there. I feel like I don't know.
And another thing,
But the problem is how they respond.
yes, another thing.
No, we
what
can
you
work
say-
on that guy as upcoming pharmacist and medical doctor.
for sure.
No.
Okay. So we
building
can
on
work
that.
together, guys.
They're building
So
on
it's starting with us, eh?
Mr.
We're
Yes,
still in the
so
learning.
yes, Mr. Karma. Yes, Mr. Karma. I'm
Get on
getting
the edge.
you.
I'm not putting on the edge, it's because I want to.
It's important to make eye contact.
Okay. Oh, let's do this. Yeah.
So bagero na bagai gang. My name is Adike. So a guy gulisa tomato. Iri 8 at temperature. Free delivery by Quincy. And then if you are not within Quincy, you can buy for at least temperature and I'm going to deliver for free. Nkubwera cheva guy. Cheers.
If you're looking for where to buy some nice, good tomatoes, you can hit us up. Our contacts are simply in our description. Thank you.
So unfortunately, we've come to an end of our first part
Why?
of
We shall work.
antimicrobial resistance.
Hey.
Of course, we'll have another session very soon. Yes, we'll come up with one. Yeah, of course, the gents had so many things to say. Lots of things to say. Yes, and for the viewers, perhaps you can tell us what you think antimicrobial resistance is, and you can tell us which side you think gave good points. Otherwise, it was Shebele Moses and the 4 gents, and it's bye bye.
Doctors Chalo.
Pharmacist power.